for amazing question and answer session as well.
Thank you.
So,
Thanks for inviting
Thanks
us.
for having us.
Okay. So sorry. It gives me great pleasure actually to introduce the next speaker. Sahil Khera did his interventional cardiology training from Mass General, and then his structural heart training from Columbia, and then his claim to fame is replacing me as the associate director when I was moving to Pakistan at Sinai, and he has since moved on and become the program director of structural heart program at Sinai. So do we have Sahil with us? Sahil, thank you for giving us time, and stage is all yours.
Thank you, Asad. That's very nice of you. Thank you for the invite, everyone. I hope you can hear me clearly, loud and clear.
Yes, we can.
And you can see my slides. Can you see my slides, Asad?
Yes, we can. Yep, we can see them. Go for it.
All right. So good evening, everyone, and Eid Mubarak to everyone in Pakistan.
Khair Mubarak.
So I'm going to talk about transcatheter aortic valve replacement, post-procedure care pathways. A slightly different topic than what John and Dwayne were presenting, but I think needlessly extremely important when you have your own structural programs. So these are my disclosures, and I will not be discussing anything investigational or any investigational therapy. So transcatheter aortic valve replacement has really, there's been a paradigm shift for the therapy itself in the last 10 years. Initially for the extreme and high risk patients, and now this has expanded into the low and intermediate risk patients, and simultaneously including all, increasing our volumes across the country in the United States and also across the subcontinent in Pakistan and India. The volume of patients that you're seeing right now has tremendously increased in the last few years. This has been the volume growth in the United States, clearly now beating isolated aortic stenosis. TAVR is now sort of the preferred therapy for the most patients and has surpassed surgery. And why is this important? So this topic, I think, is extremely important because as your volumes grow, you have to define how your structural heart program is going to work. And you need to have solid post-TAVR care pathways, which include immediate as well as subsequent care. And once the TAVR is done, your job is not over as a structural interventionist. You have to make sure the patient undergoes a safe discharge, is otherwise safe from all sort of, post-procedure complications. So I've divided management of these patients in sort of two pathways. One is the immediate, the other one's subsequent. And the immediate is basically prior to leaving the operating suite. What are some of the characters you want to look at? What are some of the things you want to look at? And the first one is obviously these patients are done with high ACTs. You want to have ACTs above 250 to 300. So you want to reverse with protamine, which is the usual dose of less than 50 milligrams. You want to make sure your access site closure is very good. You want to have an ideal blood pressure before the patient leaves. You don't have any blood loss. Your distal pulses are very good. And you have good neurological status for these patients. That means you have to delineate between a true stroke or sedation recovery, especially in the older patients who are recovering from sedation. Nowadays, we've moved away from a GAT approach, and most of our TAVRs are done with minimal sedation and TTE. But if you are doing some of your cases, some of your valve-in-valve or complex bicuspids or left main protection or the like, under TE, you want to make sure that you have good sedation recovery in these patients before they leave. Immediate intra-op telemetry and temporary pacer removal. I think this is really important, especially if you're using one of the 34 self-expanding valves, if you're using valves in patients with prior conduction system disease. And the most important thing, in my opinion, is the take home for an immediate post-procedure care. You want to make sure your patient is awake and reasonably oriented. The access site is without any overt warning signs. There are no focal neurological deficits. Patient has a stable EKG unless there is known conduction disease. And if this patient had a neckline, for example, it's a oversized valve 34 or one of the 29 sapiens, a patient has a prior right bundle branch block, left anterior fascicular block, and you've secured a neckline, make sure the neckline stays, and then only the patient should be transferred out. So these are the post-procedure care pathways for immediate care of these patients. Now, once they leave your operating suite, that's when I call the subsequent post-procedure care. And this I've divided into some of the complications that you see and how you tend to mitigate them. So subsequent, the most important thing you want to look at the patient's hemodynamics. So there are certain aspects you want to look at, heart rate, blood pressure, respiratory rate. How we do it here is for the first hour, we check it every 15 minutes. For the next 5 hours, every 30 minutes. And then every hour for the first 18 to 24 hours post-procedure. And after that, Q4 hours till discharge. So you want to make sure you're on top of the hemodynamics of your patient and what are some of the issues that you deal with in a post-procedure TAVI patient. A lot of our patients have high beam gradients. They're females, they have small left ventricles, and they could have dynamic intracavitary gradient, sort of akin to the suicide, RV in pulmonic stenosis. You relieve it, and these patients become hypertension. So how do you treat them? Volume resuscitation and phenylephrine. So you want to keep an eye out for these patients. If the patient has low preload, you had some bleeding or a hematoma, hemorrhage, hypovolemia, these patients need to be made sure that there is no sort of complication, no vascular complication. You want to make sure you do a good imaging and clinical exam. The third type we see is distributive shock, where patients have a low systemic vascular resistance, a classic ICU shock. Make sure you have adequate ICU care for these patients. Rarely do we see cardiac tamponade nowadays. We have such good CT sizing, and we have all, as the world as a whole has gained so much experience with TAVR that we don't see much of aortic dissections, root injuries, or RV perfs. But if we do, you want to make sure you have a low threshold for sort of bedside pericardiocentesis. You have your CTS team, or you can get a quick CT scan. But CT scan is relatively far-fetched in these cases. You want to just go quickly, train the effusion. And the other thing, if you're doing a lot of complex high-risk cases, patients who have low EF to begin with, patients who have acute decompensated heart failure, sort of these urgent, emergent TAVR cases, or patients who have had a coronary obstruction during the procedure, these are low inotropy states. You want to make sure these patients have a careful wean, and you should not rush to remove inotropy in these cases, and if need be, possible short-term MCS or a CHF concept. The other thing is thrombocytopenia. Most commonly you'll get a call from your colleagues or your nursing team that, hey, the platelet count has dropped. I mean, it's pretty common, all right? So we do CBC and platelet check every Q8 hours for the first 24 hours. Transient thrombocytopenia, I would not be worried. It's extremely common. It's rarely associated with HIT. But if you have severe thrombocytopenia, which is less than 50 after TAVR, that really is a strong predictor for early and long-term mortality. Similarly, anemia, almost 50% of patients are anemic. This is the patient population you're treating. And if you have persistent anemia post-procedure, it's never really a good sign. So this, I think, is more of an indicator of patients who are frail, they're coagulopathic, they have multiple comorbidities, they have liver disease, kidney disease. So I would not be too worried about thrombocytopenia. You see it. For the most part, these patients, the platelets will return to normal in a day or two. Vascular complications, as Dwayne was alluding to, we have really done a good job in sort of reducing our vascular complication rates for like around 130 TAVRs we did this year so far. We've had 0 vascular complications, and I think part of it is because of our meticulous planning with CT scan. For vascular complication monitoring, our strategy is very simple. It's Q15 minutes for the first hour, incision and vascular site monitoring. Next 30 minutes, every 30 minutes for the next 5 hours. Q4 for the first 18 to 24 hours, and Q12 till discharge. But remember, when you're examining for vascular complications, you want to make sure that this is in addition to hemodynamic monitoring, which I think is extremely important because they go hand in hand. Most common, you'll see hematoma, pseudoaneurysms, acute limb ischemia, closure device injury. Rarely you'd see retroperitoneal bleed, aortic dissection, LV perfs, and annular ruptures, which are sort of more catastrophic. And like I said, that we've really done a good job, and this is data from Sherwood published in CCI in 2020. Some of the biggest risk factors were female gender, peripheral vascular disease, if you have a bigger sheet size than 17 French, and if you're doing an open cut down. But the technology has really changed. We've become really good at CT planning. We have a very, very good vascular surgery team here who we collaborate with for alternative access. So our vascular complication rates for percutaneous transfemoral TAVR have really gone down. But if you do have a vascular complication, it's absolutely associated with very poor 30-day and 1-year outcomes. That has been shown in multiple studies in the past. Neurological complications, I think this is extremely important, and I'll tell you why, is because we consistently see a lot of strokes. We have a lot of calcified aortic stenosis here compared to the subcontinent where it's more fibrotic, younger patients, bicuspids. We see a lot of tri-leaflet, tricuspid calcific aortic stenosis. The risk of stroke is around 2 to 2.5%. That's what we tell our patients. That's what the data we have. And the issue is that despite all the procedural experience that we have gained over the years, the stroke rates have essentially remained unchanged. And that's a topic for separate discussions, a whole talk on what to do with stroke. But I'll just tell you what our Mount Sinai protocol is in managing these patients. Most of these strokes happen in the first 24 to 48 hours. And that was published by Dr. Samir Kapadia, and which I think is extremely important because post-procedure related strokes is going to happen in the first 48 hours. If you have a long stroke in next week or two, that's probably not related to your procedure. It's more related to the patient comorbidities and chronic atrial fibrillation. So these are some of the risk factors that we look at. Patients who are in general, high risk of stroke predicted by their CHA2DS2-VASc. If you have a CHA2DS2-VASc more than 5, that's a high risk of stroke. Patients who have severe peripheral vascular disease, they have a high risk of stroke. Older patients have a high risk of stroke. If you have new onset AFib, that's a high risk of stroke. There are obviously anatomic factors. If you do longer procedure times, if you do too much valve repositioning, as Dwayne was alluding to some time back, you do post-dilatation, it's questionable, but we still talk about it. And if you have a small, aortic valve area, or if you have aortic atheroma, that's a high risk for stroke. But anytime you have a late stroke, that's probably related to chronic AFib, in my opinion, and mostly leaflet thickening. But these are some things to think about and sort of define, how to manage these patients with stroke, how to diagnose, how to quickly be on top of it.
Sahil, 2 minutes.
So we published this data from our own institute. And I'm going to show you how we manage and sort of check these patients. So whenever a TAVR is done, patients get neurochecks every hour for the first 4 hours, and then every 4 hours for 12 hours, and then every 12 hours till discharge. Now, the key here is once you have recognized that the patient is having some focal neurological deficits, you want to make sure you get your CT and CT MRI or CTA quickly. The key here is these patients are very different from acute ischemic stroke that you see elsewhere in the hospital. These are mostly, non-embolic strokes. These are calcified chunks. This is not classic thrombus. So the role of TPA is something we questioned, and that's how we published this entire protocol, is that I think there's no role for TPA in these patients for the most part. So
Sahil,
if you have an intracranial hemorrhage, you have to get neurosurgical consultation.
Sahil, 1 minute.
If you do a CT,
There's
if
1
you do a
minute
CT
left,
scan
1 minute.
and it's negative for a large vessel occlusion and you have non-disabling symptoms, if your neurologist says these are non-disabling symptoms, they're absolutely conservative therapy. You don't need to give TPA in a patient who's just had a large bore access, procedure. If you have a large vessel occlusion on CT scan, these patients should immediately go to neurosurgery and interventional radiology evaluation. If
last 1 minute, Sahil, that's why I was calling you.
Thank you. And if you have a CT negative for large vessel occlusion, but NIH stroke scale is more than 5 and patient has disabling symptoms, you have to sort of discuss this bleeding risk with the interventional cardiologist. And the patient's prohibitive or high bleeding risk, you cannot give TPA. If it's a low bleeding risk, you can give TPA. But again, the role of TPA is limited. Focus more on quick mechanical thrombectomy if you can. Then the last is rhythm and conduction system. We've discussed this many times before. Patients who have baseline right bundle, if you're using a self-expanding valve, pre-existing first-degree AV block, oversizing or low implant depth, you should be worried about permanent pacemaker, and you should monitor these patients. Last but not the least, early ambulation, removal of Foley, trial of voiding, and restarting home medications. So I think I finished on time. Thank you very much. I'll take any questions.
Perfect. Thank you very much. Thank you. Excellent. Okay, so Sahil, stay back for the question answer session if you can. I know you're busy. So if you can, please do. And then we're going to go to the next talk. It's by Ahmed Al-Momani, who is Assistant Professor of Medicine, Cardiology, and a Structural Heart Interventionist at UT San Antonio. Do we have him online?